right. In this section, we are going to talk a little bit more in detail about cardiac muscle and then the electrical activity of the heart. So, we briefly touched on cardiac muscle tissue weeks ago when we did the tissues chapter. We're not going to go into a significant amount more detail here, but we are going to talk a bit more in detail about these muscle cells. So again, cardiac muscle cells are also striated, but they're shaped a lot differently than skeletal muscle cells. So we're getting those Y or X kind of shapes that are forming in these cells. They're only going to have one, maybe two nuclei, generally speaking, versus skeletal muscle. And these are going to be much, much smaller cells than skeletal muscle cells. So we saw skeletal muscle cells are pretty large and they can get pretty long and stuff like that. Cardiac muscle cells are not going to do that. They're not going to get particularly long because they're going to be structured a lot differently. They have a very different function. All right, and so we are going to get all of this cardiac muscle tissue by combining all of these cells together end to end and getting that fusion between these different muscle cells. And the connection point between them is called an intercalated disc. And so this is going to help support the electrical impulses that are traveling through these cells. So the heart is really, really special because it has something called autorhythmicity, which is basically that the heart can generate its own electrical potential at fixed points in time and frequency that's going to spread rapidly from cell to cell, causing them to contract. And so the heart does get partially controlled by the endocrine and nervous systems, but it does not require input from either of those systems to just beat at its normal resting pace. It is going to generate those electrical signals all by itself. We'll get into that in a little bit. But the structure and connections between these cardiac muscle cells are going to help make sure that that electrical signal spreads through the muscle cells properly. So because we are also looking at striated muscle cells here, we're still going to have those basic contractile units of sarcomeres. We're still going to go ahead and see those dark A bands and light I bands of the myofilaments and everything like that. So all of those contractile elements, the parts of the cells that are actually doing the contraction, that sliding filament theory, they are all going to be pretty much identical to skeletal muscle. We've still got the T-tubules going down into the sarcolemma, allowing the electrical impulse to reach that interior portion of the cell. One big difference between skeletal muscle and cardiac muscle is that these T-tubules are found only at the Z-discs. Meanwhile, in skeletal muscle, they're found at the junction of the A and I bands. So there's only about half as many T-tubules per cardiac muscle cell than there are in skeletal muscle cells. Sarcoplasmic reticulum of cardiac muscle cells are going to store only a few calcium ions. So most of the calcium for muscle contraction here in the heart has to come from outside of the cell. And this means that we have a slower onset of contraction, but we have plenty of mitochondria so that we can generate that cross-bridge cycling for those contractions. And they are also going to undergo that aerobic respiration, just like skeletal muscle tissue does. So again, these cardiac muscle cells, as you can see, branch pretty freely, and so these intercalated discs, again, are really important for passing that electrical impulse through for contraction. So the intercalated discs are formed by portions of the sarcolemma, so the special plasma membrane of muscle cells, that have really special integral membrane proteins that form desmosomes that we can see down here. As well as fascia adherens that are indicated down here. So these kind of finger-like projections. And then we also have some gap junctions that you can see here indicated in green. So these are all connections between the sarcolemma of different cardiac muscle cells, and they've all got their own special jobs. So the desmosomes and fascia adherens, they're going to be the ones anchoring the cells together. So those finger-like projections really help actually anchor into the adjoining cell. The fascia adherens are also going to hold actin filaments directly into that sarcolemma, and so that is going to help with that muscle contraction a lot more. And then gap junctions also allow ions to pass from cell to cell, and this is really important again for that the cardiac muscle contraction. Because we really need synchronized contractions. We need everything to contract in the same fashion, in the same order, and everything like that. There's some other connective tissue that's going to help bind the cells together outside of these different junctions, but we're not going to get into a lot of detail about that. But we really need that strong connection because there's going to be a lot of force happening with these contractions, and then they are also going to really need that passage of those electrical signals through the cells. All right. So there are two main types of cardiac muscle cells. There are contractile cells and conducting cells. So the myocardial contractile cells do exactly what their name implies. They're the cells that are doing the actual muscle contraction that is causing the heart to beat and pump blood. All right. They make up about 99% of all of the cells in the myocardium layer of the heart. And again, these are autorhythmic, but that is what we are using to actually get that heartbeat. And then the myocardial conducting cells, that other 1% of the cells, these are usually going to be a lot smaller than the contractile cells and don't have as many myofibrils for contraction because their job isn't to contract. They are going to be very, very specialized cells that initiate and send out electrical activity to trigger the other cells to actually contract. All right, and these tend to be pretty isolated to certain regions of the heart, and we're kind of seeing that image here. So those cells are isolated to a couple main places: the sinoatrial node up here at the junction between our right atria over here and the superior vena cava. And then we also have the atrial ventricular bundle, which is going to be right here, kind of towards the top of the right ventricle and right before we turn into that pulmonary trunk. All right. The atrioventricular bundle can also be called the bundle of His. And then they also have these abbreviations, the SA node and AV node. So the sinoatrial node is going to be what establishes our normal cardiac rhythm, so basically our resting heart rate. And so these are going to go ahead and generate that electrical signal that sets kind of the pace of the heart rate. So these are considered to be the pacemaker cells of the heart. This initiates what is called sinus rhythm, which is just that normal electrical pattern of the heart. So they're going to generate that electrical signal, and it's going to spread kind of down through that atria and then also over to the other atria, over to that left atria, through what are called internodal pathways. All right. So the atria will contract based on the signaling. So they're going to contract because that's part of that pathway. And then they're also going to kind of travel into this next node as well. And this AV node is being signaled by the SA node ultimately to contract. But we don't want these both initiating those contractions at the exact same point in time, because then we would get atrial and ventricular contractions at the exact same time, which, like we already talked about in the last video, is not necessarily going to be a good thing. That could cause a lot of issues with blood flow. It takes about 50 milliseconds for the electrical impulse to travel from the SA node to the AV node. So not a lot of time, but we do need that little bit of a delay again so that we're not contracting atria and ventricles at the exact same time. And so once that AV node gets signaled, it's going to generate some electrical impulses that are going to travel over the ventricles and go ahead and signal those to actually contract. So this is how that conduction signal kind of spreads through the heart here. So starting over here at 1, basically this is when the heart is at rest briefly. And so once that sinoatrial node initiates its contraction over here, we've got those little arrows starting to go out. It's going to initiate that electrical signal, the action potential, sweeping across the atria. And then it's going to reach that atrioventricular node over here. There's going to be, again, that delay so that the atria and ventricles are not contracting at the same time. So we've got this purplish color showing that signal has passed through the atria. They are going to contract. We can see those valves are going to be open in this particular point in time, but we are not getting signaling to the ventricles just yet. Coming down here to 4, that's going to trigger again that AV node to generate its electrical signal. It's going to follow kind of a slightly different pathway here. Now we've got our valves closed, so those are going to generate that electrical signal through the ventricles. And so we've got that spread here indicated by that purple shading on this particular heart here. In step 6, that's when we get that ventricular contraction, so those muscle cells are going to go ahead and contract. Again, those atrioventricular valves are closed here. We do not want blood flowing back into the atria, and so that is that ventricular contraction to pump blood out through the pulmonary trunk or aorta. And so we can kind of trace this electrical signaling through the body by doing an electrocardiogram. And so an electrocardiogram is frequently referred to as an ECG or EKG. Those mean the same thing. And 12-lead ECGs are pretty common. And so the placement of them is going to help go ahead and detect some of these different signals. And so we'll look at a reading from an ECG here in just a moment, but this is a really important tool that doctors have at their disposal now to catch some abnormal heart rhythms. Those are called arrhythmias. Relatively common. A lot of people have really mild ones that they're never going to notice and are not cause for concern. There are ECGs that use 3 or 5 leads only instead of 12, but 12 is kind of considered to be the gold standard because it's going to give a lot more information. And so the lead refers to the cable that is actually doing the recording and kind of tells you that difference in voltage. So these are going to be placed, as you can see here, kind of around the heart right there. So the heart's going to sit right about here. So we're trying to detect that sinoatrial node signaling and then the atrioventricular node, as well as the spread of that signal through the rest of the heart, and then how long that signal takes to get out to the rest of the body. There are slightly different versions of this. They are referred to as continuous ambulatory electrocardiograms. This is usually going to be a small, portable, battery-operated device, usually known as a Holter monitor, that's going to continuously record the electrical activity, usually for about 24 hours. There's some longer-term ones that can be used, and even some that can be implanted under the skin and left in for longer periods of time. But these are all going to give kind of the same general information that is going to show how that electrical impulse is spreading from the 2 different nodes and through the rest of the heart. So this is what a readout of an electrocardiogram is going to look like. Some of you may or may not have seen this already. And so what we're seeing here is a normal heart rhythm. And so a lot of you that are going into nursing or medical school or something, you're probably going to learn a lot more about this at that point in time. We're just going to briefly touch on it. And so there's a bunch of letters here that tell us different pieces of information. So this P wave right here is generated by the start of that electrical impulse from the sinoatrial node. So that P wave is kind of the start of that contraction process. And then the spread of the electrical impulse from that AV node through all of the branches of that node is going to go be this, what's called a QRS complex right here. And so we can kind of see some depolarization happening, and then we're going to have that increased electrical signal, and then we're going to come back down. And then we have a T wave afterwards, and that is going to be the activity associated with repolarization, so the movement of ions back into their original starting concentrations. And so any differences in how long it takes to get in between some of these phases can indicate some of these arrhythmias. So we have this PR interval, so how long does it take from the start of that sinoatrial node signaling to that atrioventricular node signaling, and then the QT interval is looking at those different steps of depolarization and is going to tell us some slightly different information. And then again, that QRS complex is looking at the actual spread of the AV signaling. We also have the PR segment and ST segment that can tell us other information as well. So these are some electrocardiogram readouts of some common arrhythmias that exist in the population. So you can see how in this one up here with the second degree or partial block, this is going to be generating a lot of P waves, as you can see, and they're not being followed by that QRS complex. And then the T waves, and some of them are. And so that's because we have that partial block, and so that's going to block some of that signaling. Here we have atrial fibrillation. So we have that really abnormal jumps in the signal right before we get into that QRS complex, and then it returns to that abnormal beat in there instead of having those nice little P and T waves. And so we have a lot more signaling kind of going through here that's not supposed to be there. And then we also have more frequent QRS complexes. All right, so those QRS complexes, that atrioventricular signaling is happening a lot more often. Down here in ventricular tachycardia, so as you can see, that QRS complex has a really weird shape, especially that S component. We're getting a big drop in that S component, and we're not really getting a whole lot of that P wave. So this is a lot of signaling kind of continuing to go through the heart at the same time as that new SA node signaling. And so tachycardia is an abnormally high heart rate. And so not only do we have a weird shape of that QRS complex, but you can see that these are happening really, really frequently because ventricular tachycardia is going to be an increased beating of the ventricles. Here we have ventricular fibrillation, and we are getting almost no electrical activity. This is very, very dangerous. And so basically this fibrillation for both atria and ventricles is just this really sudden, continued, repeating contraction of the heart. It's basically not actually going through the depolarization and repolarization process the way it's supposed to. And it's just kind of continually generating those electrical impulses, trying to get the heart to beat a lot. And then a third degree block down here. This is also going to be really severe, so we can see a little bit of P waves in here from that sinoatrial node, and they're not reaching that AV node. So there should be some extra QRS complexes right about here and right about here. And so we're kind of skipping that signaling to the AV node when we're not supposed to, and that's just because we're blocking that signaling here. And we will talk about coronary circulation in the next video.